Okay, welcome to everybody who's watching right now. This is Dr. Kukreja of DFW Bariatrics and General Surgery. I am happy to do our bariatric seminar for you today. And so we offer this seminar to two different sets of patients. We offer this to new patients as well as patients who are going through their preoperative workup, because we think it's really important that our patients be educated in what we're doing here and why. And so congratulations to you. This is really the first step as someone goes through this journey to help improve their health. That's really what this is about. This is not about the bathing suit or anything like that. This is about your health, and doing this alone generally is not advised if at all possible. So enlist the support of others around you as you go through the journey. We never, maybe that's just my personality, but this is my basic background. I've been doing bariatric surgery for quite a while now, finished my training back in 2009 and did specialty training in just bariatrics after that. And so we've been doing this for well over a decade now, and DFW Bariatrics and General Surgery is our practice that was established back in 2016. Previous to that, I was directing two other bariatric programs. And so one of the things I'd like to highlight is I'm a medical director of our metabolism program at Methodist Dallas Medical Center, as well as I train fellows from UT Southwestern, which I think is, those are two things that help to differentiate us. Additionally, do a lot in the way of academic medicine. I publish, I present, I keep track of our data. And I think in 2021, so far, we have 4 peer-reviewed publications, and I'm working on a book chapter right now. We do a lot of national presentations, international presentations, and are really just thought leaders in the space of robotics and bariatric surgery, and teach other surgeons as well. And thankfully have about 5,000 cases behind me thus far, as well as being double board certified in general surgery, as well as obesity medicine. My partner, Dr. Hooper, is also a very well-trained surgeon. Her and I both trained together back in Chicago. And she's also double board certified, as am I, well published, well practiced. And we were fortunate to have her join me last year. Jillian is our PA. She's wonderful. She joined us recently as well. So despite the COVID downturn, we were able to keep growing the practice. And I think that's really a testament to our wonderful patients and our strong outcomes. So she helps us to take care of our patients before surgery, during surgery, and after surgery, and is a huge part of our practice as well. So the team is seen here. The team has grown a little bit since this picture was taken. Once we can go outside and take a nice picture without sweating all over each other, I think we'll go ahead and do another picture soon. So, this is myself and Dr. Hooper there, as well as our whole team that's committed to our patients' success through this journey. We have the pleasure or misfortune, depending on how you look at it, out of having to operate out of 5 hospitals in town. Here you can see the 5 hospitals. What is not shown are 2 of the surgery centers that we go to. So Medical City Dallas and Methodist Dallas are 2 of our primary hospitals. We also operate out of Presby Dallas City Hospital, as well as Baylor Frisco. And that's largely dictated by the payers and the insurance and scheduling. But the point is we can operate, all over this. I guess they're about 30 miles apart in total. So we can take care of most patients, if not all patients, from DFW. So not every nail gets a hammer in our office. We are not a factory. We're here to take care of our patients and offer them customized therapies for their journey, because not everybody has the same body, the same health issues, or the same goals. And so we were able to offer what our patients need to be successful. And so we also do more than just surgery. We teach other surgeons, we teach residents, we teach fellows, we teach medical students, we're mentoring, we're writing, and we're presenting our data. And so we're much more than just surgeons. Obesity is a sad disease in the sense that it's carried on the outside, but what's seen on the outside is often reflective of what's happening on the inside. And there's 272, I believe, medical problems attributable to obesity. And here's just a few of them. Diabetes and blood pressure being some of the mainstays that we're certainly targeting. And what's fascinating is we see people's improvement in their health so quickly after bariatric surgery. In fact, 3/4 of our diabetics will leave the hospital without any diabetes medications. So anyway, we do a lot of things to help our patients' health. And this obviously goes beyond what people may look like, but it's more important how they feel. So there are patients that come to us because their PCOS is standing in the way of their pregnancy, their joint disease stands in the way of getting joint replacements. And we're actually able to objectively reduce the possibility of cancer, of 9 different cancers in our patients as well. Some of the data, bariatric surgery is extremely well studied, and there's a profound amount of data available. We know that migraines get better, depression gets better, sleep apnea, high blood pressure, reflux, cholesterol, diabetes, the list goes on. And so we know that obesity is probably the most complex disease in the body, and treatment of it is certainly complex as well. We're able to really help the whole patient through bariatric surgery. And unfortunately, obesity is a silent killer. Every day it's cutting a little bit off of someone's life. But it does come back and get them. And this is a study of about 8,000 patients who had surgery, 8,000 who didn't. And they broke the two groups down by above a BMI of 45 or reduced or BMI under 45. And they were definitively able to show that over time, the people who had surgery were living longer, and the people who didn't have surgery were not living as long. And so we know that we are providing people longer, and not only longer, but better quality of life with bariatric surgery. So medical weight loss, when people say, well, why do I need surgery if I can just do it? Or oftentimes we have patients with naysayers in their family or their spouse who say, just eat less, exercise more, and you should be okay. And the data shows that, weight loss surgery or bariatric surgery helps people to lose 9 times more than they would have with a diet and exercise program. And then the durability of that goes much further. And so medical weight loss is important. I have good colleagues who are involved in medical weight loss. We do some medical weight loss in our practice as well. But it's hard. It's hard, and it's not durable, because we know that as people go through diet and exercise programs, and you probably know this in your everyday life, you lose weight. When people are talking to you about their diet and you're doing a diet and you're having behavior interventions, but after time, the weight comes back. And that's because food is all around us. The drive to eat is strong. The drive to eat gets stronger when you lose weight. And so this is all good arguments for bariatric surgery and its merits in people who are heavy and truly need to lose weight. We use BMI to stratify people's height and weight and determine if someone's obese. It's not a good scale. It's very crude, in fact, but it's all we've got. And so you may know your BMI, you may not know your BMI. You can look at your BMI here, but what you will notice is that BMI has nothing to do with you. If you're a man or you're a woman, has nothing to do with if you're white or you're black. Has nothing to do with your bone density, has everything to do with just your height and your weight. It's that simple. So if you're 5'5" and a BMI of 35 at 5'5" looks like 210 pounds, and a BMI of 40, which is where we do surgery on people without health problems, is 240 pounds. So BMI of 35 is considered class 2 obesity. BMI of 40 is considered class 3 obesity. This is just a different way of showing the same thing. We're typically able to offer surgery above a BMI of 35 with health problems, or 40 without health problems. There are some exceptions to that. There are also some exceptions the other way. Sometimes we're able to offer surgery below a BMI of 35, but it really depends on the patient, their goals, and their health conditions. There are a few non-surgical procedures that we like to discuss: endoscopic sleeve gastroplasty and gastric balloon. Insurance never pays for these procedures, so they're self-pay procedures. The gastric balloon has been around for decades, maybe not in the United States, but it's been around for decades, with over 600,000 implants worldwide. We know this procedure is safe, it's effective, and it lasts for 6 months. So we put a balloon in your stomach. 6 months later, we take it out. That balloon weighs about a pound. It is heavy, and it takes up room in your stomach. And so 15% of people don't like their balloon. They want it out before 6 months. And initially at balloon placement, most people have some degree of nausea and vomiting, but that gets better after a few days. Endoscopic sleeve gastroplasty is another self-pay or cash procedure. And in this procedure, using endoscope through the mouth, you see we're inside the stomach here. Using endoscope through the mouth, we're able to shrink the stomach to make it a narrow, small channel that doesn't accommodate as much food. And so this is a nice procedure, not reversible, not removable. It's intended to be a permanent procedure to shrink the stomach down, sometimes referred to as the accordion procedure. Typically results in about 20 pounds or 20% total body weight loss. That needle we use is a big needle, but rarely does it cause any injuries on the inside. Dr. Hooper and I specialize in robotic surgery. It's a platform or a technique that we embraced quite a few years ago, back before it was cool. And we did that because we know that our outcomes are better. Our tissue dissection is precise. And so we're able to offer robotic surgery for our patients. That doesn't mean that the robot is doing the surgeries for us. You can see here, this is traditional laparoscopy. It also involves small holes. Robotic surgery involves small holes as well, but I am controlling the robot, or Dr. Hooper is controlling the robot. And so we're able to very precisely control what's happening inside the abdominal cavity as we're operating. So there are three surgical options for bariatrics, the first being sleeve gastrectomy, the second gastric bypass, and the third is duodenal switch. So sleeve, bypass, switch, each is different, each has its own value, each has its own outcomes. You can see the first picture there is for sleeve, and when we do a sleeve, we remove about 2/3 of the stomach. That stomach is removed. This is not reversible, this is not removable, this is not redoable. Once this is done, it's done. The second procedure is gastric bypass. And you can see with the gastric bypass, the top of the stomach is made into a tiny, tiny, tiny little pouch. And then we connect your small intestine to that pouch. And so the large portion of the stomach there is excluded or bypassed, hence the word gastric bypass. The third procedure there is duodenal switch. When we do a duodenal switch, we're basically making the stomach into a sleeve. And then beyond that sleeve, we're bypassing a decent amount of the small intestine to result in malabsorption. With sleeves, typically involves one night in the hospital. Surgery itself takes roughly an hour. And this banana-shaped tube results in about 60% weight loss with 60% diabetes resolution. Your medications will be unaffected. Any medicines that you're on can still be taken if they need to be taken. And this operation works by restricting A, how much you eat, and B, by reducing ghrelin. Ghrelin is the hunger hormone that comes up whenever it's mealtime. And so without that ghrelin, you don't get as hungry. The risks of this procedure include leaks. Leaks are uncommon, typically about 1 in 400, 1 in 500 patients. We've had 4 leaks in the last 11 years, so we're happy with that. Our leak rate is far below national averages. The other thing to worry about is heartburn or reflux, and that can happen about 10% of the time. And so there's 10-year data around sleeve. Is there any long-term repercussions of that heartburn? We don't yet really know. We do know this procedure is not reversible and typically involves 2 or 3 pills a day between the vitamins and calcium that we ask that you take. Although they're not reversible, they can be revised to other procedures. Duodenal switch gastric bypass is a bigger operation, takes a little bit longer, but it's been around a lot longer, been around since 1961. Operation results in a little bit more weight loss, a little better diabetes resolution, and that gastric pouch that we're making is quite small. So this operation is also considered to be irreversible, although I have reversed them in select circumstances when medically necessary. It's not easy to reverse, but it can be reversed if needed. The risk of leaks after bypass are very low, less than 1%. You can also have hernias on the inside, ulcers, vitamin deficiencies, or dumping syndrome. Dumping syndrome happens when too much fat or too much sugar is eaten at one time, and that causes the bowel to dump. People get flushed, they may have diarrhea, they may get headaches, their blood sugar may drop. So this helps to keep people away from those foods. The last operation that we're going to discuss is duodenal switch. And duodenal switch has become more popular in the last few years, especially as sleeves get revised. Typically, this is the most aggressive of all the operations, the best diabetes resolution rate, 95+% diabetes resolution rate, least likely to have weight regain, and people lose weight over about a two-year period. Surgery can take a little bit longer, up to 3 hours. And this is an operation that really does require vitamin compliance to do well. So patients must stay on their vitamins forever to do well after this operation. It's also, I would consider to be a low risk operation, but the risk can be a little bit different than the other procedures. Leaks are always a concern, visceral injuries. The other things to remember is because of the fat malabsorption, there's a higher rate of people having smelly farts, for lack of a more sophisticated word, as well as diarrhea. The fat soluble vitamins are at risk, like A, D, E, and K, which is why we replace them so aggressively, as well as bone density, which is why calcium is also replaced. Patients who take their vitamins, they do just fine. Patients who don't take their vitamins don't do just fine. We can revise surgeries when necessary. In fact, 30% of our cases are revisions of some sort. We revise lap bands, we revise sleeves, we revise bypass. And these are typically for issues around reflux or weight loss or ulcers. And so we can do that when necessary. Typically, we will revise lap bands to sleeve or bypass in 1 or 2 stages. We will revise sleeves to bypass or switch. And we'll revise bypass, either distal bypasses or duodenal switch in rare circumstances. Of course, with bariatric surgery, there's a little bit of a process. There's what your insurance requires, there's what we require. Every insurance plan is going to be different. They may require 1 visit to the dietitian, 6 visits, 12 visits. And so we have to work with your insurance company to make sure that they're happy. They're also going to require a psych eval. Some even require your PCP to be involved. We always want to make sure our patients are well taught through seminars like this. And then we want to make sure that you're healthy enough for surgery. And that includes a cardiac evaluation, esophageal evaluation, and so forth. So I like to briefly go over the data because bariatric surgery is so well studied. I can plug in our patients to a database and predict what they actually are going to expect. And so I can plug in this patient. This is a 40-year-old female who's not Hispanic with a BMI of 41 and non-insulin dependent diabetes and high blood pressure. And you can see the chance of her having a leak with a sleeve is way less than 1%. Sleeve is red, bypass is blue, and yellow is duodenal switch. The risk go up ever so slightly. So her weight loss, however, is shown here with a sleeve. That patient with a BMI of 40, who's 40 years old, should lose a little over 60 pounds, bypass almost 80, and switch about 93 pounds in that first year and still losing. Her blood pressure is going to get better. Her diabetes is going to get better. As you go more aggressive with surgery, you get more aggressive results. But either way, her diabetes resolution is about 60% at lowest and about 80% at the highest. So our patients tend to recover pretty quickly because we do a lot of things to enhance their recovery. We do nerve blocks, et cetera, to control pain. Most of our patients have 5 incisions. Only 15% have enough pain that they want narcotics. And so you can see here, this is one of our patients who came down from Arkansas. She came to our support group meeting the following night after her surgery. And you can see she was doing great there on the left the day after surgery. And here she is 6 months later in the same outfit, looking great, feeling great. So these are only tools. Our patients do really well, I think, because of the teaching that we do, and they're very committed. But we've seen patients who don't do so well because they don't use these tools well. And so change is important, durable change is important, and the surgery is there to help you make those changes. So through the process, we have responsibilities as a practice. We're going to help you through this process. We're not here to judge you. We're here to keep you in the loop. But we do ask that you also verify your insurance, just as we do, because we don't want to get different information. We ask that you keep us in the loop as well, so that we can get your surgery done on a timeline that is appropriate for you. If you are one of our patients, thank you. If you're not one of our patients and want to be one of our patients, you can see here, we do a free insurance check right on the top of our website, DFW Bariatrics and General Surgery. You can plug in your insurance and we will get back to you by way of text and email right away to ensure that you know what your bariatric coverage is. Our practice is centrally located outside downtown Dallas, so we can take care of patients from Dallas, from Mesquite, Arlington, Fort Worth, and we actually have a patient coming this week from North Carolina. So we have patients coming from all over to get our care. So thank you very much for your attention. I hope there are some questions. If there are, please feel free to put a question out there and we'll answer them as best we can. You can always call the office 469-620-0222. If you hit up our support group on our Facebook page, we can help you there as well. So thank you very much for your attention tonight, and I will field any questions that show up in the chat or anywhere else at this time.
Yeah.
Okay. So thank you, everybody, for your attention tonight. Please give us a call in the office when you're ready to move forward, and we're happy to help. And take care. Be